بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد أشرف المرسلين. أبناء الحباء طلبة كلية طب الأسنان جامعة الأنطرة. معاكم الدكتورة إيمان عبد السلام شاكل، أستاذ ورئيس قسم الاستعاضة الصناعية بجامعة الأنطرة. Clinical Remove Prosthodontic 4 اللي هم Level 5-2. Now we complete the radiotherapy. Definition of the radiotherapy: therapeutic use of ionized radiation in the management of neoplasm of the body without surgery or as an adjunct palliative treatment after surgery, either in combination with or without chemotherapy. An important concept in treating head and neck cancer is organ preservation rather than relying on major surgery. An organ preservation approach first uses radiation and chemotherapy to shrink the tumor. This allows for a less extensive surgery and may even allow some patients to avoid surgery. Indications of radiotherapy in head and neck: squamous cell carcinoma of the soft palate, floor of the mouth, tongue, lips, and buccal mucosa. Adenocarcinoma of salivary and mucous gland. Primary lymphomas of nasopharynx, tonsils. Carcinoma of maxilla and mandible. Carcinoma of piriform sinus and subglottic area. Here we have types of radiation. Electromagnetic waves. Wavelengths less than 1 Armstrong, called photons. No mass and no charge. For example, X-rays, gamma rays. Another have mass and charge. For example, electrons, protons, neutrons, alpha particles. Types of radiation therapy modalities: external radiation therapy, internal radiation therapy. External radiation therapy, most commonly modality of radiation therapy, also called teletherapy, used to deliver high doses of radiation to tumors that are located with 6 cm of skin surface. When external radiotherapy is used, the doses are of order of 6,500 rads to 7,500 rads for 6 to 7 weeks. Fractions: radiation therapy given in a series of treatment or fractions. Most radiation therapists deliver external curative radiation therapy for oral tumor in about 30 fractions, spread over a 6 to 7 weeks period. Energy source: the following energy sources are used for external radiation: low energy source, X-ray, also voltage 200 to 250, high energy photo. دي بعض معلومات عن الدوز، طريقة أخدانها، جرعتها قد إيه. ده for information، يعني معلومات لكم تبقوا أنتم عارفينها، لكن ما هواش المضمون من المحاضرة إنك أنت هتكلم لي كواحد بتاع علاج أورام بالإشعاع. هو المفروض إن إحنا هنا هندخل على الأبلاينس والقصص دي، هي دي اللي أنتم المفروض تبقوا منوطين بيها. والمريض اللي هو بياخد راديو ثيرابي هنشتغل له طقم السنان امتى لو هو حابب يتركب له طقم سنان، والتايم تو ستارت، هل هو during radiation، هل بعد الراديشن، وبعد الراديشن بقد ايه نبدأ نشتغل. ولازم نبقى احنا عارفين الافكت، السايد افكت of radiation on the oral mucosa, on the bone, on the gland, on the salivary gland, all of this. Industrial radiation therapy also the same. This is for you information. These are for factor important is the dental management of patient receiving radiation therapy. العوامل اللي هي تهمنا في مريض الأسنان اللي بنتعامل معاه وبيستقبل radiation therapy. يهمني جدا ان انا اعرف الدوز الجرعة بتاعته. انجريز دوز بياخد جرعة كبيرة، ده معناه ان في انكريز للدمج هتوقعه على الميوكوزا والبون والتانج والساليفري جلاند وكل القصة اللي هي في الاورال كافيتي. المود اوف ديليفري يهمني جدا المود اوف ديليفري اوف راديشن. اكسترنال سورس هيزود الدمج للادجacent structure. radical neck dissection decrease the blood supply, increase the risk of damage. الtype of radiation. الobesity increase the obesity, increase the damage. الage increase the age, increase the damage. هي العوامل ديت اللي تخليني اخد بالي واعرف بالظبط قد ايه الدمج اللي انا هتوقعه من المريض الدنتال اللي انا هتعامل معاه، واقدر ان انا عن طريق قسم الاشعاع اللي هو بياخد او الدكتور الراديو ثيرابي يديني معلومات عن الدوز بتاعته، هاي دوز والويفز بتاعته قد ايه واخدها مده قد ايه. كل ديت بتديني انفورميشن ان انا اتعامل مع المريض ده امتى بالظبط. هنا التيشو افكت زي ما احنا عارفين في immediate effect immediate على الابيثيليوم، وعندي histological picture epithelium is pale وthin وlow creatine, decrease الفاسكولاريتي وincrease الفايبرس fiber. prosthetic problem long term ulcer intolerable prosthesis. طبعا لو في اي ulcer اتكون لاي مشكله في البروسيس اللي احنا مركبينه للبيشنتس، هنا هيبقى في long time for healing الالسر دي. buccal mucosa, vasodilation of the blood vessels, inflammation of the mucosa. Now in the lip, cheek, tongue we have also effect on the salivary gland. We have also effect in decrease saliva وممكن يبقى فيه xerostomia. ده بيخلينا نعرف انه نوع من الامبريشن ماتيريال احنا هنستخدمها وانواع ايه اللي نتجنبها contraindicated to be used during impression. السكن ده فيه redness وswelling وايروجن. الكورنر اوف ذا ماوث هنلاقي فيه angular cheilitis. الايز هنلاقي فيه conjunctivitis. weight loss and dyspnea. On the salivary gland هنلاقي فيه effect decrease the amount of saliva والفيسيكوستي بتزيد و decrease the pH of saliva وفي difficult في swallowing. Prosthetic effect, the patient cannot tolerate these procedures due to more friction during function as saliva act as an effective lubricant. Retention is compromised as the peripheral seal may be difficult to obtain. طبعا احنا عارفين الدور بتاع السلايفا في الريتنشن في الكومبليت دنشر. دي اللي هي الحاجات اللي هي الديلي. on the eye هنلاقي فيه كاتاراكت وهنلاقي فيه دامج لعدسة العين. السنان والبريدونتال ليجامنت تيث اند بريدونتال ليجامنتس هنلاقي دي كالسيفيكيشن وفي sensitivity، في distraction للتوث buds، في arrest للتيث. again tongue and mucosa partial complete loss of taste diet، في loss of appetite ونوزيا وبين. السكن في erythema والسريشن وبيجمنتيشن. البون maxillary bone effects is more than the mandibular bone due to more radiation absorption. بيبقى عندي osteoradiosis. trismus. When the TMJ and the muscle of mastications are in field 3 to 6 months after therapy, fibrosis of the muscle fiber, impaired mastication, and limited mandibular movement 10 to 15 millimeter. Treatment include exercising and the use of dynamic bite opener, and we have it. Now, the dental management of radiotherapeutic patient, we have treatment divided into pre-irradiation treatment, post-irradiation treatment, prosthodontic treatment. Pre-treatment evaluation is important because many of the complications of oral cancer therapy can be reduced or eliminated by proper treatment and management of oral disease prior to treatment. Evaluation of the patient's levels of the oral hygiene, thorough hard and soft tissue examination, complete periodontal examination, complete radiographic examination, making radiotherapy prostheses, stent used to help the radiotherapist in the treatment of the oral malignancy by radiation, like tongue positioning device, shielding device, fluoride. The following must be removed. All caries and periapical diseases should be documented and eliminated prior to cancer treatment. Teeth in the field of radiation must be extracted prior to therapy to avoid osteoradionecrosis. Periodontal involved badly decayed or questionable teeth should be removed before therapy. Sharp bony spicules, all these must be removed before starting. The following teeth must not be removed: teeth within the tumor to avoid dissemination of the tumor cells. ما نقدرش إن احنا نشيل السنان اللي موجودة عشان ميبقاش فيه انتشار للtumor cells. Teeth of unaffected side if a radiotherapist allow that. Conservative strict oral hygiene lenses with hydrogen peroxide, warm saline, antibiotics and analgesic in case of infection and pain. Any surgical intervention is contraindicated. ده هيؤدي إلى massive tissue loss. يعني هيبقى لو في ورم واخد مساحة كبيرة هيبقى في distractions للبونز للقصة دي كلها الموجودة. Prophylaxis against tooth decay, treatment by 10% stannous fluoride application. Side effect of therapeutic radiation: loss of taste, mucosal ulcer, pain, candidiasis, erythema, xerostomia, cervical caries بيبقى فيه rampant caries, osteoradionecrosis, epithelial atrophy, tremors and fibrosis. Alteration of taste sensation: radiation may directly affect taste buds. However, changes in the saliva xerostomia can also affect the taste. The loss of taste sensation could be permanent in some patients. Mucositis. While mucositis related to chemotherapy develops within a few days of treatment, radiation mucositis begins during the second week of therapy. Here, the earliest manifestation is the development of white discoloration from the lack of sufficient discommodation of creatine. This layer is soon lost to be replaced by atrophic mucosa, which is edematous and friable. Ulcers soon develop and are covered by a removable yellowish pseudomembrane. Now the pictures see the effect on the mucosa appear. Xerostomia, dry mouth, is a frequent complication of radiation therapy as saliva glands are very sensitive to radiation. The effect may begin within a week irritation of the radiation therapy. Dramatic decrease in saliva flow can be noted during the first 6 weeks, and further decrease may occur for up to 3 years. The return to normal is quite variable and dose is related. The patient should be instructed to rinse frequently with sterile water saliva, use commercially available artificial saliva substitute, use salivary stimulants such as sugarless gum or candy or drug therapy, apply lubricant agent to lips to prevent cracking, This is هذه الطرق إن إحنا نعوض حكاية xeroostomia, absence of saliva, which act as a lubricant for the tissues to decrease the effect of the xeroostomia on the mucosa and in the oral tissue. So we have 4 methods to avoid or lessen the side effect of the xeroostomia. We have radiation caries. This rampant form of dental caries is xerostomia induced. Radiation caries is predominantly cervical in location. Prevention of radiation caries, the patient education 10 to 14 days prior to radiation therapy. The patient should receive a complete prophylaxis, including scaling if necessary. Brushing and flossing techniques must be reinforced. Fluoride program. Fluoride program should be instituted and maintained. Sodium fluoride is best tolerated by patients with an oral mucositis compared with stannous fluoride. Fluoride gel delivery is best accomplished through the use of a custom tray. Daily 5 minutes application is recommended during therapy with weekly office visit. They should have this principle. Amalgam has been the restorative material of choice. If caries occur in the presence of daily fluoride usage, then the patient should increase the frequency and the duration of fluoride application. When pulpal pathology is present, the tooth can be treated by conventional endodontic therapy. No surgical procedure should be attempted, and the patient should be placed on antibiotics. Extraction teeth should be avoided. Osteoradionecrosis, radiation damage the osteocytes and microvascular system of the bone, leaving it hypocellular, hypovascular, and hypoxic. Osteoradionecrosis is one of the most serious complications of radiation to the head and the neck. It occurs less commonly today than in the past because of the better treatment modalities and focus on prevention. The jawbone will contain non-healing dead bone areas. On radiograph, osteoradionecrosis appears as an ill-defined radiolucency that may develop zone of relative radioopacity as dead bone separate from the vital area. Pain, cortical perforation, fistula formation, surface ulceration, and pathologic fracture may occur, as appear in the X-ray and the clinical case. Prior to therapy, the following should be performed. All questionable teeth should be extracted if they cannot be restored. The vascularity of bone decreases following radiation therapy. Post-radiation extraction should be avoided. All oral foci of infection should be eliminated. A program for excellent oral hygiene should be initiated and maintained. Treatment of osteoradionecrosis. A healing time of at least 3 weeks between a dental procedure, such as extraction and the initiation of radiotherapy, significantly decreases the chance of bone necrosis. Conservative treatment consists of gentle debridement with the removal of sharp bony spicule and non-vital bone, use of antibiotic packs, and frequent irrigation. General dentists may wish to call upon the oral surgeon for more aggressive surgical treatment and the use of hyperbaric oxygen. Trismus. Fibrosis of the normal soft tissue that fall within the radiation field is often an insidious complication of radiation therapy. Trismus typically occur progressively from 3 to 6 months after the conclusion of radiation therapy. As the result, jaw opening can be severely limited. Prevention is the best treatment for trismus. Once it occurs, physiotherapy consisting of stretching exercise and special appliances can sometimes be useful. Here there is a tongue depressor, mouse screw, therapeutic device, like here, treatment. Denture placement of denture timing. Time to insert the placement of the denture or to begin the starting of the working impression like this. Denture construction for irradiated patient should be made from 12 to 14 months had elapsed for mucosal healing. Some patients may wait from 2 to 3 years before mucosal has recovered sufficiently to tolerate the denture. Success of prosthodontic treatment depends on preoperative data, dose, tumor prognosis, field irradiation, thorough oral examination, degree of the trismus, salivary function, to high tissue attachment, enlarged maxillary tuberosity, flabby tissue undercuts, and are undesirable to engage post-radiation symptoms. Prosthodontic treatment, non-traumatic and non-irritating denture, effective follow-up system. Primary impression should be made with alginate, not compound. Border molding done by low fusing wax or heavy rubber base. Secondary impression should be made with rubber base, no zinc oxide not used. Jaw relation, low vertical dimension of the occlusion over low force and less. Centric relation record should be achieved with no trauma. Try in. Modified anatomic or flat teeth should be used to decrease the horizontal force. Denture base should cut away to minimize irritation. At insertion, any roughness or sharp angle should be removed. Never use soft liner. In some cases we must use soft liner. Xerostomia should be treated by using petroleum jelly. Lingual flange shouldn't use to gain more retention and only for follow-up. First 2 weeks daily follow-up, then once every 6 months. Positioning stent, recontouring, shielding, positioning radioactive fluoride stent. Here I discuss and explain this in the last lectures. Here there is some pictures to demonstrate the positioning. Here also pictures for the tongue depression allow focusing on the clinical tumor and reducing. Here for the shielding, some pictures for the positioning radioactive like this. Thank you, and for any questions feel free to contact me بروفيسور دكتور إيمان شكل أستاذ ورئيس قسم الاستعاضة الصناعية بجامعة الأنطرة. حبايبي الطلبة، هنا موضوع الراديو ثيرابي. تقدر تستفيد من المحاضرة دي والمحاضرة السابقة، لأن المحاضرة دي هي فيها مانجمنت لحالات الزيروستوميا هنتعامل معاها ازاي، حالات الدريسمس هنتعامل معاها ازاي. في صور للراديو ثيرابي ستنت. أرجو إن أنتم تستفيدوا من المحاضرتين، وأي كويشنز ما في مشكلة إن أنتم تقدروا إن أنتم تتواصلوا معايا في أي وقت. Thank you. السلام عليكم ورحمة الله وبركاته.